let me know when you'd like me to go to the next screen. Thank you.
Okay, so today so osteoporosis I'm going to talk about today, and a little bit about diabetes, but really the main thing to know about osteoporosis and diabetes is that people with diabetes are more prone to developing fragile bones. And so it may not look based on traditional parameters like somebody with diabetes has osteoporosis, but in fact, they are more likely to break a bone despite those somewhat normal looking parameters. Next slide. All right, so today we're going to talk about how do you define osteoporosis, the diagnosis of osteoporosis, and then how to treat it. Next slide. So if you think about osteoporosis as having the definition of being thin and fragile bone, then you will not go wrong in identifying people with osteoporosis and treating them accordingly. A lot of times we look at certain measures and think, oh, they don't qualify as having osteoporosis because this scoring system looks good. But in fact, there are a lot of ways that we can define or diagnose somebody with osteoporosis that have nothing to do with scores on paper. And if we just think of osteoporosis as being fragile bones prone to breaking, then we will be treating people better. Next slide. So on the left, this is a picture of bone. On the left is normal bone, and you can see it's very dense compared to the picture on the right, which is bone that has osteoporosis. So again, you can see it looks almost like a honeycomb and lots of hollow spaces on the right. And those little connectors between all those holes on the right are very weak little connectors. So you can imagine if a baseball bat were made out of the left hand bone and you swung it and hit something, you'd be fine. But if the bone on the right were to make the baseball bat and you swung that, you're likely to have it crack and probably break in half. Next slide. So how do we diagnose osteoporosis? So the very first way that we pretty much always think about it is a special kind of X-ray of the spine and the hip called a Dexa Scan. And that provides scores. And the score that we look at mainly is called a T-score. And osteoporosis is found on a Dexa scan when someone has a T-score that is minus 2.5 or more negative than that. Next slide. So this is a picture of a Dexa scan report. So when we order a Dexa, this is what we get back on paper. And I drew a little arrow pointing to where you identify those T-scores, and you can see that it says under the arrow, don't pay attention to the words young adult. That doesn't mean this person isn't 90 years old. It's comparing the 90-year-old's bones to the bone density of a young adult who presumably has healthy bones, strong bones. So the T-scores are right below that arrow. You can see on the left, the word left on the left and go across, and it says minus 2.5. Those other scores are slightly more positive than that, but that worst T-score identifies this person as having at least some parts of their body that are gonna be fragile. And therefore, this person should be diagnosed with osteoporosis. Next slide. And that person should get osteoporosis treatment. And as far as treatments, we'll talk about that later on in the talk. Next slide. Okay, so one way to diagnose osteoporosis is this Dexa scan with T-scores that are minus 2.5 and below. Next slide. Okay, so what are some other ways we can, what other way can a Dexa report tell you that someone needs treatment for osteoporosis? That paper that we were just looking at where I had drawn the arrow with the T-score, there was a lot of information on that page. And there's actually additional information there that we need to practice looking at, because what if that T-score doesn't say minus 2.5 or below? There are other things on that paper that could indicate to us that this person still has fragile bones, despite the T-scores looking not so bad. Next slide. So the other thing that's on a Dexa report is something called a Frax Score. And I'll show you on another slide where to locate that on your Dexa Scan report. The Frax scoring system is something that the radiologist usually does at the time of the patient's Dexa scan, or you can do it in your own office. And it is assessing several different risk factors that somebody could have that could make their bones more likely to break. So for example, it asks about the patient's age. We know that the older a person is, the more fragile their bones are. Women are more likely than men to have thinner bones at baseline. How much do you weigh? Have you already had a fracture? Did one of your parents break their hip? Do you smoke? Do you drink a ton of alcohol? And have you already had a Dexa scan? And if so, what was the T-score on that Dexa scan? And then this questionnaire calculates what we call a Frax score. And you can see that in that bottom right corner in the red box, the words major osteoporotic, and then to the right of that 19, and then below that hip fracture and 4.9. Those are your Frax scores, and I will explain on the next slide how do you interpret those. So Frax scoring, I lied, it's not this next slide, but the Frax score basically tells you the 10-year percentage risk of that first line said major osteoporotic fracture. That was the one that said 19. And the Frax score also tells you the 10-year percentage risk of a hip fracture. And that was the one on the previous slide that was 4.9. Next slide. Okay, how do you find that Frax tool anywhere? You can go to the App Store, they have one. You can go online and download it. You can go to Hippocrates, they even have one. If the same little app, you look up medications, there's an Hippocrates version of the Frax tool, easy to find. Next slide. Okay, so here's what I was saying. On your Dexa scan, you see my new arrow, and that's pointing to the 10-year fracture risk of a major osteoporotic fracture. For this patient whose Dexa this is, they have a 19% risk of a major osteoporotic fracture over the next 10 years. For hip fracture, they have a 3.6% risk of a hip fracture over the following 10 years. Next slide. Okay, so when do you use the Frax score? You use it when, next slide, the T-score is wishy-washy, okay? So if your T-score on your Dexa scan says minus 2.5 or worse, you know that that's osteoporosis because we're all taught that that number means osteoporosis and you treat them with osteoporosis medicine. On the other end of the spectrum, if the T-score is greater than or equal to -1, that is normal bone density and you don't need to treat them. But what if the score, the T-score, is in that gray zone when it's less than -1, but it's still greater than -2.5, which we know of as osteopenia. That gray zone means your bones are not great, but they're not terrible. Okay, so that's called osteopenia. Next slide. So when your T-score indicates osteopenia, that gray zone of T-scores, that is when you need to look at your Frax score. This is the only time you need your Frax tool, and your Frax score is to help differentiate a person with low risk osteopenia versus high risk osteopenia. Okay, so osteopenia is not just one little bucket and you say, okay, go use your vitamin D, calcium, get weight-bearing exercise, and we'll do a next DEXA in 2 years. There are low-risk osteopenia people and high-risk. Next slide, please. Okay, remember that there were 2 lines. Major osteoporotic fracture was a certain percentage, and the hip fracture was a certain percentage. So you need only one of these to be bad to indicate that this patient has high-risk osteoporosis. So if the major osteoporotic fracture percentage risk of a fracture over 10 years is 20% or higher, that is high-risk osteopenia. If the hip fracture one says that their 10-year likelihood of breaking their hip is 3% or higher, that's considered high-risk osteopenia. Either one of these, if you say that either one of these is high-risk osteopenia qualifying, they need to be treated for their fragile bones. And you can say that they have osteoporosis because remember, osteoporosis is not defined by a number. It is defined as fragile bones, prone to breaking. So high-risk osteopenia, based on Frax scores, qualifies people for needing treatment. Next slide. Next slide. All right. So what if it's a low risk Frax score? So less than 20% for a major osteoporotic fracture and -3 or less than 3% risk of a hip fracture. Those are the people that you treat in the way that we've traditionally thought to counsel people for osteopenia. You tell them, make sure you get adequate calcium in your diet. And if you don't, you take a supplement with an optimal level around 1,200 milligrams of calcium for your day. Make sure their vitamin D levels are normal. And if they're not, tell them to take a supplement. People with osteopenia who are not getting, well, any osteopenia, but especially if they're not going to get treated with medication, you want to counsel them to engage in regular weight-bearing exercise. Keep your bones remembering how to be strong and holding up things. They don't need to be weightlifting and things like that. But I tell people, if you're grocery shopping and you're putting your groceries away and you have a can, lift it over your head a couple times before you put it in the cabinet. Okay, and then balance enhancing exercises. If you don't fall, you don't break your hip. So you make sure that they are doing things to help enhance their sense of balance, whether that's yoga, Tai Chi, or just standing on one foot periodically with their other foot only this high off the ground, train their cerebellum. Okay, and also to clear out their house of things that can make them trip. Next slide. Okay, so a little review. Diagnosing osteoporosis, we can use our Dexa Scan. A T-score of -2.5 and below qualifies you as having osteoporosis and you should be treated. A Frax score, major risk of osteoporotic fracture greater than 20% or hip fracture greater than 3% qualifies anyone with osteopenia to be treated for osteoporosis because their bones are fragile. So how else can we diagnose osteoporosis? There's another way. Next slide. Okay, a little reminder, osteoporosis, it means fragile bones. So people who need treatment are those at high risk of fracture. Next slide. Fragility fractures are the third way to diagnose osteoporosis. So this means, it's a term that refers to any fracture in the spine or hip after minimal to no trauma. So for example, you're standing or walking, just standing height, and you fall and you break something, your spine or your hip, or you trip on a step. I tripped on the curb and broke my hip. Now, you can also have a fracture in the proximal humerus, the pelvis, or the distal forearm, and those also count as locations for a fragility fracture. So feet, hands, and your skull, they do not count. If you break a bone in your foot or in your hand, that does not get to qualify you as having fragile bones in general. It's sort of excluded from this category of fragility fracture. Next slide. Okay, now for me, sometimes when I'm talking to a patient and I'm trying to figure out, do they need osteoporosis medicine? And this comes up in this situation. The patient comes to me and their Dexa scan looks fine. They don't have minus 2.5 or worse. Their Frax score does not put them into the high risk category, because in those situations, I don't have any dilemma. I just treat them for osteoporosis to strengthen up their bones. But suppose they have the low risk osteopenia and they just came to me because of a broken arm. And they say, well, you know, I fell down a step. It's hard to know, was that something that was an indication of the fall being hard, or that the bone is just weak? Okay, you need to ask some clarifying questions of the patient. And something that I found helps me ask in a clearer way to the patient, I say, if you were 20 and you had fallen in this exact same way, do you think you would have broken this bone? And if they say no, no way, well, that means their bones are fragile, not that the fall was hard. So then you have to think, okay, this is a fragility fracture. This is not me telling you it's always easy to tell once you ask this question. Sometimes it's still up in the air, and you just have to use your best judgment about whether or not they should be treated for fragile bones or not. But sometimes asking a question in this way has helped me kind of get to the bottom of the real definer. Is the bone weak, or is it that the fall was hard? Okay, next slide. Okay, just a summary again. So Dexa scan with a T-score minus 2.5 or below, one way to diagnose that somebody's bones are fragile and need treatment. The Frax score, which you use in people with osteopenia T-scores to delineate the high risk osteopenia people and the low risk. So 20% and 3%, or a fragility fracture. If you have a patient with any of these, please treat them for osteoporosis to help strengthen their bones and make them less prone to falling, less prone to breaking something. Next slide. Okay, so you can go to the next slide. It's just a goofy little cartoon. Okay, so why do we need to treat? Osteoporosis is common and fractures are a consequence of it. 1 in 2 women in this country who are over the age of 50 will have an osteoporosis related fracture in her lifetime. That is huge. Okay, so if you break one thing, you're even more likely to break another thing that year. So if you can help people strengthen up their bones, this statistic can change over time. Also, once somebody has a fractured hip from osteoporosis, they are more likely to die in the next year, up to 30% mortality within the year after a repaired hip fracture. And for men, it's even worse. And those things the mortality comes from a number of different things that are hard to define. But for example, you're laid up, you might get a bed sore, you're not taking deep breaths, so you get pneumonia, or you get a blood clot, or you get depressed and don't take care of yourself anymore. There are a million reasons for this mortality rate to be occurring after a hip fracture. It's not that they're dying from the hip being broken, but it is the beginning of the end, unfortunately, for many people, because it lays them up. Next slide. Okay, so how do you treat osteoporosis? You encourage people to do weight-bearing exercise. If they're gonna be able to do anything cardio, you want to encourage them to walk or run if they can. Walking is an excellent exercise, but this is in contrast to, say, swimming. Swimming is an excellent cardiovascular exercise, but it does diddly squat for your bones because the water is holding you up. So walking is something I encourage my patients to do all the time if they're able to. Also working on balance and coordination, things that will make them less prone to just falling. Dietary supplement of calcium, like I mentioned earlier, and vitamin D. They need to stop any controllable risk factors, or at least you advise them to. Like if they're drinking a lot or smoking, tell them to cut that out. Then we're going to talk next about the actual medicines. These are the ones we're going to talk about. Oral bisphosphonates, IV bisphosphonates, Denosumab, Teriparatide, Bala Peritide, and Romosozumab. Next slide. Okay, so oral bisphosphonates have been out for the longest period of time, since the 1990s. So we know them best, and they are still excellent, excellent medicines. So the two that work best are Alendronate and Resedronate. How to dose them is here, 70, they're both once a week by mouth. You take them with a big glass of water. Here's what you have to tell patients when they're gonna take it. Stay upright. They don't have to stand. They can just sit upright. Just don't go lay back down for at least an hour after you take it, so it can't kind of ride back up the esophagus and cause some gastritis or esophagitis symptoms, cause a little bit of reflux. Next slide. Also, you should always know, and I don't need to tell any of you this because you're all professionals, but know the black box warnings of medications that you prescribe, like the back of your hand, and be the first person to tell your patients about those black box warnings, because you know they're going to be watching TV at midnight and they're going to hear some lawyer telling about osteonecrosis of the jaw and how come my doctor didn't tell me about this and I've been taking Alendronate for a year. So always counsel your patients before you start so that they know that you're aware of these issues and you've talked to them about it, answered their questions about it, and yet despite this, you're still saying to them, you still need this medicine, okay? So osteonecrosis of the jaw, you tell your patients if they need major dental work, get it done before you start treatment. Also, you can explain to them that statistically the risk of developing osteonecrosis of the jaw is less than them getting struck by lightning. Truly, that is the statistic that's true. An atypical femoral fracture is also extremely rare. If it happens, it's usually after many years of uninterrupted use of these medications. So to help minimize the risk of this, we do drug holidays. Next slide. So for these oral bisphosphonates, after they've been on them for 5 years, you stop it for a year or two, and then you can restart it. Okay, the only time you do not do one of these holidays is if this person is at very high risk for fracture and continues to be so despite the 5 years of Alendronate use. So if the risk of a fracture is significantly higher than the risk of an atypical femoral fracture, then don't stop it. Keep them on the medication, because this risk of a fracture is so low, and this risk of an osteoporotic fracture is still very high. So you definitely don't want to stop the medication. Next slide. Okay, so IV bisphosphonates, there's only one that we use for osteoporosis. There are others, but just zoledronic acid for osteoporosis. To dose this, you write a prescription, 5 milligrams IV, and it's once a year. Some places are set up to do these in their office. It takes about 30 minutes, or you can set it up at a local infusion center. You advise your patient about this flu-like syndrome, kind of a prodrome, for the first 3 days or so after the first infusion. Usually they don't get it after the second infusion, but it's kind of like fevery, sweaty, headachy, you don't feel well, but explain that this is going to happen before it happens to them so that they're prepared for it. They can take their ibuprofen or acetaminophen, stay hydrated. As long as they're prepared for it, it never kind of feels so bad to the patient as if it's a completely unexpected thing and they think this medicine is killing them. And it's not bad. It's a mild flu-like syndrome. Next slide. Okay, so for IV bisphosphonates, the things you need to counsel your patients about, black box warnings, are the same as for the oral ones, the osteonecrosis of the jaw and the atypical femoral fracture. Next slide. We do drug holidays. Oh yeah, bisphosphonates for both the oral and IV. That you don't use them if their GFR is less than 30 or 35. You can use it anywhere above that. Or if they already have hypocalcemia that's not treated, because to help the bones get stronger, the way that these medications work partly is they kind of help push the calcium back into the bones a little bit. And therefore, if you already have low blood calcium levels and the osteoporosis medicine is moving that blood calcium out of the blood into the bones, you can have severe hypocalcemia, and you don't, of course, want to cause that for anybody. Next slide. Can you go back 2 slides for a second, please? So I didn't list this on here, and I should have. So we talked about the drug holiday after the oral bisphosphonates after 5 years of use. For IV bisphosphonates, the drug holiday is after the 3rd dose. So remember, it's 1 dose a year. You do your 2nd dose the year later, the 3rd dose the year later, and then you give them a year or 2 off before you can start redosing it. Okay, thank you. And now we can go back up to 2 slides ahead. All right. I don't know if anybody has any questions so far, or I can't really see, but chat.
I can monitor the chat for you. I don't think we have anything in there yet, but if anyone has questions, they can unmute as well. Okay. So the next medication is a different class. So the previous ones were bisphosphonates, and there are oral ones and IV ones. Now we're moving to a totally different class of osteoporosis medicine. There's only one in this class at this point. It's called Denosumab. The way to dose this, you write a prescription for 60 milligrams sub-Q, and it's every 6 months. People come to the office for this. It is essentially, I tell people, it's like a flu shot. That's the size of the needle. It's just a little shot in the arm, and that's it. You can use Denosumab with pretty much any kidney function. So that is one of the things that could potentially help make you choose this as your osteoporosis treatment option if the GFR is low, less than 30, 35. Next slide. Just like the bisphosphonates, osteonecrosis of the jaw and atypical femoral fracture are in the warnings. Next slide. Now, drug holidays for Denosumab, completely different than for the bisphosphonates. For Denosumab, we actually recommend not doing any drug holiday, to the point that if somebody at their 6 months from the last injection is due for their next one and they don't get it, we harass them. They need to get their next shot, okay? Because taking a break from Denosumab without starting a different type of osteoporosis medicine, like after your last Denosumab injection, your 6 months is ready for your next shot, start your Alendronate. Fine, absolutely fine, but you need something, because what they have found in the last 3 or 4 years is that suddenly stopping Denosumab actually has a temporary increase, significant increase in the risk of multiple vertebral fractures. Okay, so not everybody gets this. And in fact, the majority of people don't get these, but you don't know who's going to get it and who isn't. And you're treating them for osteoporosis and stopping a medicine, you need to start the next thing around when the next dose of Denosumab would be due, or even a little earlier. So really no later than 6 months after the last shot of Denosumab. Next slide. Okay, A little bit of troubleshooting advice for you. If you have a patient, you've started somebody on a bisphosphonate or denosumab, and they call you and say, oh, my bones are aching, then it's probably from a transient hypocalcemia, okay? This is more likely to occur in people who have underlying vitamin D deficiency. So if you're planning on starting somebody on an osteoporosis medicine, specifically the denosumab or bisphosphonate type of medicines, make sure you have their vitamin D level tanked up to 30 or above. Okay. You can tell people when they're home and calling about this, pop in some Tums. You can take a couple every 20, 30 minutes until those aches and pains go away. You just want to resupply the blood level of the calcium. Next slide. Okay, next set of osteoporosis medications, they're anabolic agents. So they build up bone. The way that the previous medicines work is, if you think about bones and the osteoclasts and the osteoclasts are kind of eating away the bone cells. Osteoblasts kind of go back in and make new ones. After menopause and after aging, those osteoblasts start to get lazier and the osteoclasts win. So those previous medicines tend to sit on the osteoclasts a little bit. Therefore, the blasts have a better opportunity to get in there and do their same old job without getting beaten down by the osteoclast activity. These medicines are actually building up bone. So teriparatide and Bala Peritide are anabolic agents. They are parathyroid hormone copies. So teriparatide, to dose it, it's 20 micrograms sub-Q each day. Comes in a pen, similar to an insulin pen, same exact little baby needle tips. The patient does it at home. Until within the past year, teriparatide had a maximum number of months of use in a human's life of 24 months maximum. Once you got to 24 months, you were not allowed to use it anymore. It no longer has that limitation. Bala Peritide is dosed at 80 micrograms sub-Q day. It comes in a similar sort of pen. The patient does it at home. It's really quite easy. This still has the limit of 24 months of use total, and then you can't use it anymore. Next slide. Okay, so what are the contraindications to these parathyroid hormone analogs? So if they already have hyperparathyroidism that's not fixed, you don't want to use this because you're giving them PTH. If they have open epiphyses for some reason, like if they're a kid, these are contraindicated in kids because the bones haven't stopped growing yet and you're giving bone growing things. And so it can mess up their bone growth. If they currently have hypercalcemia, you need to fix that. If they have Pagets, because remember that you're stimulating bone growth, and with Pagets, they have abnormal bone growth going on. So you don't want to stimulate that. If they have osteosarcoma or have had it, or bone metastases, or a history of radiation treatment. It doesn't matter where the radiation went. It always gets to the bone wherever it is. So even if it was in their skull, well, this teriparatide, it doesn't care what bone, it's telling all the bone to grow. So if you've had any radiation treatment to a part of your body, you could have some mutations in those bones that if you then prompt them to grow, could grow into some sort of abnormal cell type. Next slide. Okay, then we have the most recent, newest type of osteoporosis medicine. It's called romosozumab. It's a sclerostin inhibitor, so it is anabolic, and in some ways it also acts like the bisphosphonate. So it suppresses a little bit of the bone eating away cells, and it helps enhance the bone building cells. To dose this, you write a prescription for 210 milligrams sub-Q each month, and it's only done for 12 months total, and people come to your office and they get the injection. This one you can use with most renal function. This one also, you've built up the bones. Once you're done with your 12 months, you need to follow it up with another medication like a bisphosphonate or denosumab to help maintain the good bone increase that you've achieved using the romosozumab. If you stop the romosozumab after 12 months and you don't give something else after it, over the next year or two, they're going to just start to lose that bone that they just accrued. Next slide. Okay, so contraindications to using this medicine if they already have hypocalcemia, or if they've had a stroke or an MI in the past year. Okay, this medicine, it's the newest, and so it's always going to sound the scariest till we have much more data. You want to tell your patients that this medicine, according to a couple of the studies, but not all, can increase the risk of MI, stroke, or cardiovascular death. Okay, now here's the data as I understand it. In the romosozumab studies, comparing it to placebo, so no actual medicine, there was no increased risk of MI, stroke, or cardiovascular death. In the studies comparing romosozumab to alendronate, there were fewer MIs, strokes, and cardiovascular deaths in the group getting alendronate compared to romosozumab. So it isn't clear that there was actually a higher than normal amount in the romosozumab group, as opposed to maybe there's actually some benefit cardiovascularly to using something like alendronate. We don't know, but this is an extremely good bone builder. It is the strongest of the osteoporosis medicines in terms of increasing your bone mineral density. So if you have a patient who is fracturing left and right, and they haven't had a stroke or a heart attack in the past year, the likelihood of this medicine actually causing them to have an MI or stroke is very low, and their risk of additional fractures from their personal history is very high. So you weigh your pros and cons. Okay, but talk to your patients about this, because otherwise they're going to freak out when they hear this on the TV commercials and wonder why you didn't tell them. Next slide. Okay, so these are just the last couple slides. There are so many, well, not so many, but there are a number of options for treating osteoporosis. So how do we decide which one to pick? There isn't really any rule. And as we all know, insurance often gets to dictate exactly what we get to prescribe for our patients, whether that's right or wrong. So I'm just going to list here how I kind of make my decisions when I'm seeing a patient. So a lot of the time, if somebody's just a sort of routine osteoporosis, they haven't broken anything, their T-scores are, minus 2.7, not terrible, but in osteoporosis range, then I will start with alendronate. It is very inexpensive, it's easy to take, it's very effective. Okay, if you want a different medicine and insurance says, no, you have to start with alendronate or resedronate, well, you can have your patient take one dose, or at least have them fill the prescription and they can tell you they took one dose. And if they had any reflux or anything like that, then you document that and say, my patient tried it and they couldn't tolerate it. And then they'll give you a few more options that they'll be willing to pay for. But alendronate is a great osteoporosis medicine. It reduces hip fractures, vertebral fractures, non-vertebral fractures otherwise. It's old and tried and true, and it's cheap. So it is a very good medicine. Next slide. Okay, so I do sometimes have a hard time deciding between denosumab, that like flu shot every 6 months kind of medicine, versus the once a year infusion IV zoledronic acid. Both of them are excellent. If the GFR is low, then I go for the denosumab, because remember, GFR under 30, you shouldn't be using the bisphosphonates. I tend to go for the zoledronic acid if there's a higher than usual risk of hip fracture. So how do I know a higher than usual risk? Maybe they already broke their hip, or they have T-scores that look significantly worse proportionally in the hip area compared to the spine area. Things like that would kind of help tip the scales in favor of zoledronic acid. Next slide. As far as the anabolic medicines, I have to admit it, I really, really like teriparatide. It is one of those anabolic agents. It helps to grow the bones, and you can now use it beyond 24 months. So it is usually approvable in people that you can identify as being at high risk for fracture. So the T-scores that are -3 or -3.5 or worse, if you document that, insurance will cover it. If they have already fractured on therapy, some other therapy, insurance will usually cover it. It's getting older and a little bit less expensive, so it's not quite as hard to get it approved by insurance. It is expensive, so if insurance isn't going to cover it well, it could potentially be money out of the patient's pocket. It is an easy shot that patients can give themselves at home, but it is a shot patients give themselves at home. So if they're not comfortable with that, they're not going to go for this medicine. It does need to stay refrigerated. So if somebody's traveling, they need a little refrigerator lunchbox thing. And like the romosozumab, once these anabolic agents stop, you need to follow it up with a bisphosphonate or denosumab to maintain that good improvement in your bone density that you get with teriparatide. Next slide. Bala Peritide, it is newer, so I haven't used it as much, although I've used it a lot, and it works very well. It's another anabolic agent. It grows bones. It is used in the same patient group that the teriparatide is used for. And in the data, it may even be a little better than that other anabolic agent at reducing certain types of fractures. And it doesn't have to be refrigerated. It is also expensive, and it's also a shot. After this, when you're done with your 24 months maximum, you also need to follow it with a bisphosphonate or denosumab. Next slide. Okay, and then the last one, the romosozumab. From the data, it is the absolute best increaser of bone, I don't know if that's even a word, but of bone mineral density when it's compared to any of the bisphosphonates and compared to teriparatide. Bala Peritide wasn't out when this was in its earlier studies. Okay, something that's important if you're reading osteoporosis literature, an increase in bone mineral density is something that you measure on a picture. It's like looking at carotid intima-medial thickness and knowing for sure that, you know, thicker means they're more likely to have a stroke and thinner means they're not. We know that it's a surrogate for the actual event. It's not an indicator of the event risk, really. Bone mineral density is the same way. It is a picture we're taking to say, yes, their bones look strong or not. But actually, there's a lot we can't see on a Dexa scan that could indicate that this patient's bones are actually quite fragile, despite the picture, or quite strong, despite the picture. So bone mineral density is not a true indication of fracture risk reduction in any of these medicines. You want to look at the data that says, yes, this results in a decrease in fracture, not an increase in bone mineral density, because that's just a surrogate, okay? But it's likely a good surrogate, and it's kind of the best we have so far. Okay, so if they're still fracturing or there's significant worsening on their Dexa scans while they're on other osteoporosis medicines, that's the time to think about using romosozumab as long as they haven't had any cardiovascular events in the past year. Next slide. Okay, so how do you monitor the treatment? You've picked it, now what? So you can do a Dexa scan every 2 years. Insurance will pay for it every 2 years. Really important to know is that if you're looking at the current Dexa and comparing it to the 2 years earlier Dexa reports, the only thing you want to see to reassure you is that there has not been significant worsening. That's the only bad news you could get from a Dexa. No change is great, okay? That means the medicine is preventing those bones from getting weaker, all right? There's a lot of debate in endocrine world about whether we even need to continue to follow Dexas once somebody is on treatment. It's not usually going to change our management. So why do we keep putting people through Dexas? All right. When you see them in follow-up, you want to ask, did you have any broken bones since I saw you last? And then there's the question of bone turnover markers. I don't do them very often. I really only use those if I'm suspecting that a patient is poorly compliant with their oral medications, because, you know, something that's supposed to be suppressing bone turnover, because it's just pushing stuff in and sitting on those osteoclasts. Well, if I look at bone turnover markers, they should be nice and low, but if they're not, it means they're not really taking their medicine. So I really don't look at that unless I'm suspicious of something. Next slide. Okay, so summary. So osteoporosis, it is very important to treat this. Despite some of the bad press out there that patients often find and hold on to more than the good press that says they should be treated, we really need to talk our patients into getting treated if it's possible to talk them into it, by giving them the proper information about the risks of breaking something, the mortality that comes with it, and clearly explaining the side effects of the medicines. Okay, you diagnose it, remember the 3 ways: a T-score, a Frax score for those with osteopenia range T-scores, or if they have osteopenia, but they've broken something just from falling over, okay? We talked about all the treatments. There are lots more than there used to be, which is great. And then just a word of encouragement to just know what you're going to be explaining to your patients, know about the medicines you want to prescribe for them, and remind them that the risk of breaking their hip is far greater than any potential rare side effect that could come from any of these medicines. So the benefits far outweigh those risks. Next slide. And that's it. Any questions?
Thank you, Dr. Perini.
Mm-hmm.
Any questions or comments? I see Melissa, you're able to hop on as well. That's great. And feel free to unmute or chat in. I'm happy to read the questions out loud as well.
You said earlier in the meeting that there is a link between osteoporosis and diabetes. That's correct?
There is, yeah. And actually the when people get Dexa scans and they have diabetes, their bones actually can look a little bit different and tend to look stronger than what they actually are. So there are some groups that are trying to come up with almost like a mini formula for a corrected T-score if somebody has osteoporosis and has diabetes, so that we're interpreting these images better. That's not a done deal yet, but you know, we used to think that, well, one of the risk factors for osteoporosis is if you weigh under 125 pounds. It doesn't have to do with BMI, it's just absolute weight. And the presumption is that you just don't have enough weight bearing down on your bones every step you take to just remind them how to stay strong. So on the flip side, if you weigh 300 pounds, your bones should be very strong because you are walking around and those bones are holding up more weight every day. Well, that's what we're finding is not actually true if they have diabetes, because the inflammatory state that comes with metabolic syndrome and insulin resistance tends to cause, it impairs bone regeneration and bone healing. And so it tends to be a worse bone density and higher risk of fracture in people with diabetes.
Look, have you heard of any patients having like broken bones in their foot?
Yeah, so the Osteoporosis Foundation, the National Osteoporosis Foundation says that fractures in feet, hands, and skull do not get to qualify as osteoporotic fractures. You know, I'm not sure, but I guess there are just too many ways to snap some of those little bones in our feet or hands. So they just don't know how to kind of assess that it was a fragility fracture versus just trauma. So they leave those out.
That's true. I don't, well, what am I to say? I'm
Yeah,
just
me
finding
too.
out there's all these kind of things that go along with diabetes. It's not like I now have kidney disease that is connected with diabetes. And now I'm having some kind of metabolic thing with my blood that also goes along with diabetes. So
Yep. Yeah, it's unfortunately a never-ending Pandora's box, right?
right.
Yeah.
Yeah, so I would go back and tell my younger self, you know, you do what they say when it comes to pre-diabetes, you know, if
Yeah.
any, yeah, because I had little kids, I was too busy, I didn't have time to eat right and all that good stuff.
Yep.
So
Yep.
now I'm paying the piper now.
Gosh, I'm sorry.
Yeah, me too.
Yeah. Man.
But it is what it is. I mean, you know, you got to do what you got to do.
Yeah. Well, looking at you, you're a Caucasian female. You need to talk to your doctor about osteoporosis checking.
I will. I see we talk about everything else on the portal, on the WVU portal.
Yeah.
So I'll just drop her a line and ask her, maybe, do I need to take one of those scans?
Yeah. Any woman over, I don't know how old you are, but the
60.
guidelines say anybody 65 or older should automatically get them.
I'm
But if-
62. That may be why she hasn't.
Yeah, it could very well be. But if you have a family history of hip fractures or osteoporosis or anything like that, then it might be worthwhile, or diabetes, you know.
Yeah.
So,
Well, thank you for letting me pick your brain.
of course, it's fun to talk.
I think I've learned more on these webinars than I learned at my doctor's office.
Well, that's terrific to hear. It is, you know, we do have the luxury of time at these things.
Yeah.
You know, so.
You're not made to see 15 patients in 30 minutes.
In this one time I had to talk, right? Exactly. All right.
Thank you.
Thank you.
Thank you so much, Jackie, for the questions. And you're always welcome to email us questions too, if you want us to send them over to any hub members. Any other comments, questions from anyone? No pressure. I just don't want to rush the session if you guys do have questions. All righty. Well, thank you again, Dr. Perini. We really appreciate it. I'll be attaching your slides to the recap email, so everyone will be getting them as well in the larger listserv.
Okay, great. Thank you.
Yeah, absolutely. We're always happy to send any materials in the recap emails because some folks can't join live, so they always refer back to the recap emails, and we've gotten positive feedback from that. So it's really nice that they can look back on the YouTube recording or the materials in the email. So
that's great.
Yeah.
Okay, thank you.
Thank you. The only announcement I have is the next session is July 27th, and Dr. Giordano will be talking about hypoglycemia. Keep an eye out for that reminder, and we'll see you all next time. Have a great afternoon, everyone.
Thank you.
Thank you. Bye-bye.
Bye.